So good afternoon, everyone. It's really a pleasure to be back in New Haven. I enjoyed my years here. And I know you had a big HIV meeting yesterday. Did some of you go to that? Yeah. So I'll be covering one of the topics that was covered in the panel yesterday afternoon. So I'll be interested to hear what you all heard from that panel as we get into the area of seek, test, and treat. But I just want to begin by thinking about the big picture, and where we stand at this moment in time. And you don't really need to see the detail on this map to recognize that the global burden of HIV disease is primarily in sub-Saharan Africa, not only, obviously, but what we still see is that the heaviest burden of disease tends to be in those countries where the health system is really weakest in terms of numbers of health providers and resources. And I think what we're really seeing overall, both in the United States as well as globally, is that we're really not seeing the increased funding for HIV prevention services that we used to see. And yet we have larger and larger numbers, absolute numbers of people living with HIV. So the good news is that globally, HIV prevalence peaked some years back. Incidence has dropped in a number of countries, including in sub-Saharan Africa. And we have some new approaches, which we'll talk about a little bit today, antiretroviral containing microbicides, pre-exposure prophylaxis, some prevention strategies, test and treat that we'll talk about, combination HIV prevention, that I think give us some ways forward, which is encouraging. And I think there's really a movement globally, and certainly in the United States with our health reform, to think holistically about healthcare systems. And if we strengthen them for HIV, it might strengthen them for care and delivery of other conditions for the population as a whole. So those are all, I think, pluses. We do know that HIV prevention works, okay? Global HIV Prevention Working Group has summarized things in the last few years. Study done a few years back showed that HIV prevention is cost savings. Now bear in mind, not every intervention we do in healthcare actually saves money. So this is actually something that really effectively saves dollars. And then in fact, if we had invested strategically enough, we really could avert half of all new infections in this 10-year time period that they looked at in this study. But we have seen dramatic success in various countries. Uganda had a dramatic drop. There may be some increasing prevalence and incidence going on now. But Australia jumped very early on their HIV epidemic among men who have sex with men. For example, Brazil has been a leader in terms of making generic antiretroviral drugs available very early on. They've been very forward-thinking in their prevention. And it's had a population-level impact. So there are strategic things we can do. And we have a number of interventions now that have varying degrees of evidence about their effectiveness, from randomized trial level down to sort of ecologic associations. And you can see for prevention, we have various approaches for preventing transmission through blood and tissue, and then maternal to child transmission, which has been one of the real success stories in HIV. And actually recently good information on pre-exposure prophylaxis to prevent primary HIV infection among men who have sex with men. So what we're going to talk about today is we're going to cover talking about testing, increasing people's access to HIV serostatus knowledge, because that's the starting point, right, for people to receive health care that will save their own lives, extend the quality and length of their own lives, as well as to help reduce transmission to others, either through sexual or parenteral transmission. We'll talk about treatment, antiretroviral therapy, both as primary HIV prevention and as secondary HIV prevention, that is to say prevention with positives, so trying to reduce infectivity and transmission from someone living with HIV to their sex or needle-sharing partners. So we'll touch a little bit on PrEP, but I'm really going to talk more about the test and treat strategy and ART treatment as a whole. And then we'll close talking about combination HIV prevention. How many of you have heard about combination HIV prevention? So it's a kind of a current buzzword, and we'll talk about what it might look like methodologically and operationally. So testing and treating. We do know that obviously people who don't know their status can't act on their own health care in an informed way, right? And we know that probably 25% of people in the United States who are living with HIV still don't know their status. So the CDC, as well as the WHO, have really promoted the idea of expanded HIV testing access, that it's cost effective. In fact, work done here at Yale, David Pelletier, has shown several years back that having every American 13 to 65 have at least one HIV test, and high-risk groups have an annual HIV test, is cost effective. Okay? And that really pushed for this policy expansion to say we really have to have more folks get to know their HIV status. Nonetheless, we still have 56,000 new HIV infections a year, right? So we know we're not reaching everyone to know about their status, and we're not doing as much with prevention as we could be doing. In sub-Saharan Africa, remember that picture I showed you? 2/3 of all HIV in the people living with HIV in the world live in sub-Saharan Africa. Access to HIV testing has grown. I work in Kenya, and they've done a tremendous job in increasing voluntary counseling and testing, and I'll talk about some other strategies they're using. But nonetheless, on the whole, it's about 1 in 5 people who've actually been tested and who may be at risk. So late-stage diagnosis is still very much the norm. People come in very advanced in their HIV disease, unfortunately. And we know it makes a difference to know your status. There have been meta-analyses that have been done in the US and in other countries showing that really, for the most part, people who test positive change and reduce their risk behaviors, their transmission risk behaviors. So that's been pretty consistent, including a 7-country study that was done showing that voluntary counseling and testing recipients were less likely to have unprotected sex. So fewer transmission events, not necessarily fewer number of partners, though. Okay, I will say that. So I've worked with colleagues in Mozambique. We did an analysis of sexual behaviors before and after, 12 months after antiretroviral therapy initiation. And there was more condom use, but there was also more sex, and there was also more concurrent sexual partnerships, which is having sex with 2 or more people in the same time period, which we now believe can be a real superhighway for HIV transmission spread. So in general, it sounds like a pretty unmitigated good, right? Everyone should know their HIV status. But in epidemiology and in public health, as you all know, we always have to think about the risks and protective factors, the positive and the negative, the unintended consequence. And so I would say that there is some limited evidence that should make us just, have a little bit of a caveat. There have been a couple of studies, Project Respect 2, which tested rapid HIV testing, same-day testing versus standard antibody testing with a 2-week period. And there was a study done in Zimbabwe, which showed that actually in the subgroup of men, they had more risk behavior after they tested. Okay, so we do want to always think about risk compensation. Will people take a message, hey, I'm negative, now I can go out and have more unprotected sex because I'm scot-free? We do want to think about that and really continue to focus on evidence-based, effective primary and secondary HIV prevention strategies. Any of you healthcare providers? You work in healthcare settings? Okay. Well, if you talk to any colleagues who do, I think they would say it's well recognized, consistent in the literature, that we don't do a terribly good job in assessing the sexual health of our patients and our clients. And that's pretty consistent in surveys that have been done over the years, including in HIV clinics. Now, wouldn't you think you'd want to talk to your HIV positive patient about how to protect themselves from other STIs that could affect their own health, or to reduce the risk of passing HIV on to their sex partners? Makes sense. Does it happen? Not always, right? For a variety of reasons. Providers don't always have the time, the skill set, the motivations, the resources. So that's a continuing problem. And they're not always offering HIV testing either, despite that policy change that I mentioned. The CDC recommends we all do that now, that we recommend testing. So we have to try to think about creative ways. What will improve providers' compliance, basically, with policy guidelines and give more access? Do we need to put prompts in emergency departments where there are high-risk folks who don't always get offered HIV testing? The FDA has held hearings on self-testing for HIV. So this will be over-the-counter self-testing, and there are trials underway right now looking at self-testing. And really, we want to reach the highest risk folks, those folks who don't yet know their status, right? And so they can't benefit from information about their serostatus and treatment options. So a couple of years ago in Lancet, a group from the WHO put out a mathematical model. And they said, really, even without having an effective HIV vaccine, which we don't have a highly effective HIV vaccine right now, if we could do a couple of things, we might be able to shift the epidemic. So what they said is, if we had universal HIV testing, test everybody for HIV, and repeat that testing every year. As soon as someone tests positive, get them on antiretroviral therapy, regardless of where they are in their disease process or their CD4 count, okay? We usually wait till people are at a certain dropped CD4 count to initiate antiretroviral therapy. And they all stayed on their medicines forever. Did a great job with adherence, right? Then we'd be able to transition from the current endemic state to an elimination phase of the epidemic within a 5-year time period. And eventually, over time, reduce incidence and mortality, and then over a longer period, reduce prevalence so that we get below the R0 reproductive rate of infection, and basically, the epidemic dies out. That was the model, and it was pretty provocative. It got a lot of people talking. There were also a lot of questions about the model and the assumptions that were built into it, which were not very realistic. You know, we don't have testing of everybody and putting everybody right on treatment. Although San Francisco General Hospital has a new policy. As soon as someone tests positive, they will put them on antiretroviral therapy regardless of their disease state. So it's an interesting exercise. But in general, that's not available everywhere. There are other people who've said, look, if we do this, we're getting people on early treatment. Although it's been shown in analysis of electronic health record data to reduce mortality, nonetheless, what's the downside? You might increase viral resistance, right, at the community level. And Sally Blower has done some mathematical modeling of data in San Francisco that suggests that might happen. And we know that people don't always take their medicines. None of us do, right? So what's the average adherence to antihypertensive medicines in the United States? Can you guess? 50%. Okay. Antiretroviral therapy? It's about 75% in the United States. It's better in Africa, actually. So, it's hard to take pills every day, right? And so the fact that people don't always take their medicines in real life, not in a clinical trial where they're coming in and they're very compliant and they're getting incentives and support and everything else, might mean they would wipe out any potential benefit from providing antiretroviral therapy that can presumably knock down people's infectivity in their sexual fluids of HIV, right? And there was actually a study in China that came out recently amongst discordant couples that really didn't see any reduction in transmission to the negative partner in a real world kind of setting. My colleague Tim Hallett, who Ted also knows, who's a mathematical modeler from Imperial College, he's actually done some modeling to show that actually paradoxically, if you don't have good coverage, if you don't really get that testing out to everybody and really get that treatment out to everybody, you might actually end up having higher long-term antiretroviral therapy costs. So it's really dependent on the epidemiologic and service structure in a context to see if it really would be cost effective. So there are some, and David Pelletier, again, who did the original HIV testing cost effectiveness study here at Yale, he's actually shown in some Washington, D.C. data that this idea of test and treat will probably increase the lifespan of people who are positive, but it may not knock down incidence, at least in a 5-year time period. And we'll come back to Washington, D.C., because there is a major seek, test, and treat study underway in D.C. that I'll tell you about. But here's the basic idea, right? Let's let people know their status. Those who are positive can get treatment and options. That'll reduce the viral load in their plasma. Now, plasma viral load and genital compartment viral load are not always completely synonymous, but anyway, it should knock down infectivity. So if they do have unprotected sex or do share needles, hopefully it will result overall in reduced transmission. And we have, this whole idea of treatment for prevention. We have data from Tom Quinn that's now, the classic study from done in Africa, showing that there really is a dose response between the amount of virus in a person's body and the sexual transmission probability to their partner, and related to the disease stage and how much viral load they have. And again, thinking about the natural history of HIV disease, there's differing probabilities of transmission at different stages. So when someone first gets infected and they're just loaded up with virus in the acute phase, transmission is much more likely. But that's a very short time period in terms of exposure that sex partners may have, and also in terms of a program being able to deliver an acute HIV prevention intervention, right? But then people live for a very long period of time in what we think of as the latent phase. There's a lot going on. When they feel fine, they may not know their status, and yet there's a long period of time where they might be having unprotected sex or unprotected needle exchange. So that's a very long time period to contribute to transmission at the population level. And then when people are very sick, again, the viral load goes up if they're not on treatment, but they probably don't feel well enough to be having unprotected sex. So we have to think about sort of the natural history and where are our prevention windows or targets, where we can actually deliver interventions to reduce susceptibility amongst HIV negatives and reduce infectivity amongst HIV positives, right? So negatives, that's a number of years that we have to deliver effective prevention. People who have been exposed, but we may have a very, very brief window of literally 72 hours to try to intervene with prophylaxis, post-exposure prophylaxis, is very short window. And then when people are already infected, obviously they can live for many years. And again, we want to support prevention with positives. So several meta-analyses have shown that delivering interventions, prevention with positive interventions with people living with HIV can be effective. And they're more effective if they contain these elements and are delivered in HIV care settings. So again, we have evidence that working with people living with HIV to reduce transmission risk is effective. Now, does every HIV clinic have an evidence-based prevention with positives program being delivered efficiently to everybody? No. And we've actually put a lot of the elements of evidence-based counseling approaches into a computer tool so that hopefully that would be one mechanism for patients to get access to that information in clinics. So we know that counseling and testing may be helpful, particularly couples testing, and this is kind of a new area that people are looking at. A lot of the HIV transmission in Africa, for example, occurs amongst stable heterosexual couples, people who are married, people who are together for a long period of time. That's actually where a lot of the risk and the transmission is happening. So couples-oriented counseling is something we're looking at more. We've talked about antiretroviral therapy. We have a large trial is ongoing to see if giving the positive person antiretroviral therapy actually reduces transmission. In the meantime, we have observational data that I'll tell you about that's quite promising. And then in the global context, it may be the case that if we treat co-infections that can often bump up the HIV viral load, that might be a way to help also reduce infectivity. So my colleague, Connie Kellum, who's at University of Washington, she's done a number of multi-study trials, HIV prevention trials. And in the context of one of her cohort studies, she was able to look at amongst discordant couples. So discordant, one person has HIV, the other one doesn't, sexual couples. She was able to show that when that positive partner went on, or the positive partners went on antiretroviral therapy, it dramatically reduced the risk of transmission to their sexual partners. Okay, so it was a 92% reduction, adjusted relative risk. That wasn't the purpose of the study, but they were able to look at the data and see that effect, right? And in fact, the one transmission that did happen amongst someone who was on antiretroviral therapy, it clearly happened when that person still had a very high viral load and had just gotten onto therapy, and the transmission event probably happened here before that person's viral load went to undetectable. And the highest rate of transmission occurred amongst those people whose CD4 counts were below 200. Now that's pretty much the minimum treatment threshold for a lot of low-income countries. The World Health Organization now recommends that people start antiretroviral therapy at 350 when they're healthier. A lot of countries can't afford that, so they start at 200. And so what Connie has seen in her data is that, well, at least that's the group you do want to focus on, get those folks on antiretroviral therapy because higher rate of transmission events. And for those folks who are above 200, then you really want to look at those folks who have very high viral loads, so above 50,000 copies. This all makes perfect sense logically. It's just good to see the data, right? Because resources are limited. right? Those people who are clinically eligible for antiretroviral therapy globally right now, it may be 30%, 40% of people who should be on ART are on ART. So we have to think about really targeting our resources. So this is a way to think about targeting, at least in terms of reducing infection. So again, this 92% reduction in the partners study was very suggestive, very interesting. But it is important to say, we've had antiretroviral therapy in the United States, for example, for a long time. We still have 56,000 new infections a year, right? And people have looked at an ecological level at the association between introduction of antiretroviral therapy and transmission. And some suggested in Vancouver that there was a positive impact. Other studies have not seen that. Again, it's an ecological approach. It's got all the problems of ecologic studies. We have problems with the incidence assays that we use. So I guess I would just say as a reminder, the idea of test and treat has a lot of appeal, a lot of biological plausibility, but it's not necessarily going to be the one, magic bullet. Thinking about treatment for primary prevention now to prevent infection in negative people. The Kesha-Bora study, this was a multi-country study that looked at HIV-positive moms continuing their antiretroviral therapy beyond delivery into the breastfeeding period, because as you know, transmission can happen at any one of those stages, antepartum, intrapartum, postpartum through breast milk. And there were really very encouraging data from that. It reduced the postpartum transmission rate by over 40%. So this is the idea of treatment to prevent transmission to a negative person, in this case, the child. After many years in the wilderness, we finally have good data on a microbicide that has worked. So in South Africa, the Capriza study found that they enrolled HIV-negative women, and there was, at the end of the study, 39% effectiveness in reducing incident HIV. And interesting again to note, the effectiveness was better amongst the women who self-reported being more adherent to using the microbicide, right? So again, we think about these biomedical interventions, they don't function in a vacuum. People still have to use behaviors to use the biomedical interventions effectively. So we have to think about behavioral adherence to all of these interventions over time. Pre-exposure prophylaxis, we now have data, again in this last year, on effectiveness for reducing HIV transmission amongst men who have sex with men. So that was very encouraging, reduced infection by a mean of 44%. And again, was a higher reduction amongst the men who were more adherent to using it. And we will be hearing more pre-exposure prophylaxis data in the next 2 years. Will be coming out of trials. So the VOICE trial is coming, which is looking at heterosexual women. We have other PrEP studies coming, and amongst other populations. So we're going to be seeing more information about PrEP. And now it really becomes this issue of implementation. So you're at the health department. Are you guys doing anything with PrEP for MSM? Did you come out with any guidance after the CDC?
No, they're still discussing.
Yeah, so they came out, so the national CDC came out with an interim guidance. Now every health department, state health department, has to figure out, well, how do we actually implement this? How are we going to deliver PrEP to the highest risk MSM or whichever population it's been shown efficacy in, right? And it's not going to be easy to do. Now we can learn from our colleagues in family planning, because they've been, for decades, they've had to, roll out new contraceptions and contraceptive services and tools, right? And they have to understand the acceptability and feasibility and operational delivery for those new devices and pills and so forth. But it is not going to be easy to get pre-exposure prophylaxis out there, paid for. When again, remember what I said, people who already have HIV aren't all on antiretroviral therapy. Now we're going to be giving antiretrovirals to negative people, so you can see the competing demands, right, in terms of resources. How do policymakers figure that out? Will it lead to risk compensation or disinhibition? Right now I'm protected, I've got, I can go out and have more unprotected sex. So I just think there's going to be some real competing issues and sustainability questions, even though, again, it's exciting that we have more evidence about efficacy and other tools in our toolkit for prevention. And of course, we still have condoms, but they remain the redheaded stepchild, basically, right? We don't have any RCTs, because why? You can't ethically randomize condom use. But we know ecologically and from other sources of data that they're effective, but frankly, they don't get used as often as they could. But they certainly need to be a component of our prevention approaches. So I'm just going to talk about a current test and treat kind of study that is being funded right now in the United States. This is HPTN, HIV Prevention Trial Network 065. It's the person who leads this is Wafa El-Sadr and Bernie Branson at Columbia and CDC. And basically, this is a very large, very ambitious kind of community study that's being done in the Bronx and in Washington, D.C. Also looking at surveillance data in 4 comparator cities just to look at trends. But it's a huge study, and all it's going to talk about is feasibility of a test and treat approach. Okay? There's no way you can look at an HIV incident outcome in the United States. We don't have the statistical power or the resources for it. So it's really just a feasibility study. And what it's involving is a couple of things. It's building on some campaigns that have been undertaken in the Bronx and in DC to try to encourage more HIV testing, right? So this is the Everybody Needs to Know in DC. They're working with all the hospitals in those 2 cities to try to get more testing done in the emergency departments and in the inpatient setting. They are randomizing some sites that they will give a coupon to the person who tests positive if they go to a clinic, an HIV care clinic. So this is this idea of behavioral economics, conditional cash transfer, give people money for the behavior that you want them to do. A little bit controversial, some evidence of effectiveness though. Then another component is that they are randomizing some of the HIV clinics in those 2 cities to also pay the person if their viral load goes to undetectable after 2 visits. So they're being paid to get to a undetectable viral load, right? Again, that's what we want. We want that for their own health and for transmission risk. And then there's a component that I'm working on, which is we also need to support people who are identified as being positive, right? Our goal is to go out there and find out everyone who's HIV positive, push them into care. Now what? Now we have to help keep them sustained in care and give support around prevention with positives, around transmission risk reduction. So we're using a computer tool that I've developed in the past with colleagues, and we're going to be doing just a traditional nested randomized trial within this larger study to look at self-reported sexual transmission risks, and how many partners they're having sex with who are known to be HIV negative or whose HIV status they don't know. So we're looking at transmission risk and delivering an evidence-based counseling, prevention with positives counseling intervention on the tablet computer. It's all audio narrated in English or Spanish, so it's between that person and the computer, basically. And this is just, to give you an idea of it, the tablet. We currently have a study of 500 people in New York City using a similar tool that's being done in Spanish, and we're starting a randomized trial in Kenya that's being done in Swahili. So it kind of delivers a counseling session that an optimal counselor would, but not every place has the staffing for that, right? So we've gone from this language of test and treat, from that original Greenwich model that said, we can end the epidemic just by testing and treating, right? Then we said, well, actually, it's not that simple. We really have to test and then help. We have to go find people at risk, encourage them to get tested, help them get into treatment, help keep them on treatment. So now the evolution of this language is really seek, test, treat, and retain. That's the very latest, if you want to have the latest buzzword, that's it. And the NIH has funded several initiatives around this, one of which is focused in correctional facilities. So I'm working with colleagues at in Rhode Island and in the Washington, D.C. jails for an initiative there. Fred Altiste, who's here at Yale, is also part of this initiative. He has a project going on. And there's now a new round of funding that they're looking to make awards for this concept of seek, test, treat, and retain in low-income countries. So let's shift now to this idea of combination prevention. We want to take effective evidence-based approaches, package them up, deliver them to the right population, and have high enough coverage that we can have an impact. And this is basically the same concept. This is kind of a term that was coined by our mentor, King Holmes at University of Washington. Just like we have highly active antiretroviral therapy that works biologically on the virus, we need highly active multiple component prevention as well. So that rather than kind of doing what we often do, which is, we develop an intervention, we test it in a single RCT, that takes 5 years to do, and then you do and that takes a couple years to come out in the literature. The idea is to move it more towards combining effective interventions so that we can ideally have an impact at the population level and in a way that's sustainable. And really the hope here is that by doing this in a more thoughtful way, we really could gain synergy, right? That's the goal, that it wouldn't just be an additive effect, but we really have some synergistic effects. So this is a mathematical model that just shows, gives a quick visual of what that could look like. If you don't intervene, what the incidence per 100 person years might be. If you only delivered male circumcision, which we know is effective, but if you just did that by itself, you get that. If you only delivered risk reduction behavioral interventions, you get that. But if you put it together, you get synergy. That's the hope. That's the goal. So there haven't been a lot of these studies done yet as such. And so it's sort of a newer area. There are a couple of different approaches people are taking. Some are combining, one or more interventions in a package. And I'll tell you about this NIH-funded initiative, MP3 initiative. I'm working with colleagues on one project now. Others are sort of looking in terms of focusing on subpopulations, the most at-risk populations, and so designing, sort of packages of things specific to a population. And then others are also trying to sort of look at structural factors as well and really put it together in a way that would be working with the community. So again, these packages will need to include evidence-based behavioral elements. What do we know works from biomedical interventions? And the structural intervention piece is often left out, but really is critical when you think about it, right? What puts people at risk? What enhances individuals' risks? It has to do with a lot of those structural issues, gender inequality, homophobia, laws against needle use. So people have been trying to look at ways to also incorporate structural intervention changes. And it can get pretty complicated looking, right? So here we go. Here's the biomedical, behavioral, structural list of interventions, right? All useful, have varying levels of evidence around them. How do you put that together? How do you choose really what's going to go in that basket? How do you deliver it at high enough coverage level to have an impact? How do you evaluate what impact you have? So there's some really interesting but challenging methodologic concerns around this. And in general, people say, again, it's taking that same idea that we've had for a while. You really need to know your epidemic. HIV is really about microepidemics. You have to know your specific patterns in a subpopulation. Who's the most at risk? You've got to deliver evidence-based interventions that reduce susceptibility and or infectivity, right? You want to cover the whole gamut. And again, you have to hope that you're putting them in the right place in a cost-effective way. So again, thinking back to our windows of prevention intervention, we have opportunities to deliver interventions prior to HIV exposure, during the point of possible transmission, and then following infection in terms of people living with their HIV after infection. So how do you pick? How do you choose evidence? Okay, you've all seen that pyramid of strength of evidence, right? Sort of case series versus a cohort versus a single RCT versus multiple RCT, systematic reviews, right? Well, we don't have every level of evidence for all of the interventions. But again, I think it follows a sort of logical pattern. We need to understand the epidemic and the patterns that we're trying to focus on. Where do we get data for that? What are the main drivers of the epidemic in that group? So if it's heterosexual couples in sub-Saharan Africa, what are the main things that are putting people at risk, and what would be the best intervention points? And then, choosing the effective interventions. So there have been strength of evidence ratings, like the U.S. Preventive Services Task Force, right, has the ratings of levels of evidence for an intervention. CDC's done something similar. So that may be one approach that people will use. And there, again, as with the seek, test, treat, and retain idea, there's some concerns or criticisms people have about combination HIV prevention. misunderstanding that it kind of means throwing everything into the kitchen sink. Well, that's not going to be good, right? That won't be working. Some people say, you just can't do it the way you're talking about designing these things and evaluating it. But actually, there have been some existing studies and projects that really essentially have been combination HIV prevention that have followed some of these techniques. And they've been carried out successfully, like in India amongst female sex workers. Other concerns are around cost, but then again, it's as compared to what? Doing single interventions, or not doing anything that's effective, or spending money on interventions that actually aren't effective, right? Which certainly can happen. So the goal would, the thought would be that if we do get synergies, it might be more cost effective. It might allow economies of scale to be delivered. We do have to look for antagonisms, though, between the interventions in these packages. Hard to evaluate, no question about it. There are real methodologic challenges here to doing that, and to thinking through causal chain and trying to parse out what the impact is. And as with all HIV prevention studies, we have big challenges. You need a place with high incidence to have enough power to carry out a cost-effective study. We still have problems with our incidence assays. And so we need really innovative designs and analytic strategies, and I think those are going to be developed as we go forward. And there is really a reliance on using mathematical modeling as a tool for all this, as a way to sift through, well, what if we read the literature, we do a systematic review, what are the most effective HIV prevention interventions for adolescents, which, by the way, there isn't much of an evidence base. Well, now let's put it into the model. So we're hoping to do a combination prevention study in Kenya, looks like we'll get funded for, where we're going to do gender-specific packages for boys versus girls, because there's different things that are needed, different risk, different interventions. So how do we select amongst those? We can model it. If we picked male circumcision and alcohol reduction, alcohol abuse reduction, and this for the boys, what would that do? As opposed to if we took this intervention out and put that one in, right? So there really is a utility to using these mathematical models, which of course are only as good as the parameters that go into them, and that are not empiricism, right? They're models, but they can still help us choose amongst interventions, and also to sort of potentially look at evaluating impact. So this was, again, Tim Hallett at Imperial College. He looked at Zimbabwe, interventions that were done that happened on the ground, and there was a dramatic drop in prevalence and incidence in Zimbabwe, probably initially because the susceptibles died out. And that's what you see here. But then over time, and there's been a lot of discussion recently about Zimbabwe and what's accounted for this drop. They had a lot of civil unrest, huge economic crises. Men had less money to have multiple partners, and people reduced the number of partners they had, right? And that could have an impact. So this Zimbabwe model is an interesting one because they've actually put this together as a toolkit that's available on the web. As a free sort of accessible tool to look at for doing your own modeling. So NIH has funded a first round of these combination HIV prevention grants. And people are doing an interesting range of things. Some people are looking at MSM in Peru. Connie Kellum is working with heterosexual couples in Uganda, which I'll tell you about. Don Desjardins is working with IDUs in Estonia. Other people are looking at, they're taking one village in Botswana and doing a whole combination package just for that village. Other people are looking at trying to identify acute HIV infection in Malawi and deliver interventions there. But as I mentioned, there's definitely a lot of methodologic concerns and, I guess, opportunities, for trying to target your population, target your interventions, think about how you deliver them in a operationally acceptable way. How might you evaluate it when you don't have tens of millions of dollars? Because there just won't be tens of millions of dollars for these six studies to move forward to an efficacy trial phase, right? And how would we identify synergy, antagonism, whether there's been additive or multiplicative effects of having these multiple interventions in a package? So the project that we have in Uganda, that Connie Kellum is running in Uganda, you can see how it walks through the approach that's recommended for combination prevention. We're looking at the drivers of the epidemic among heterosexuals in sub-Saharan Africa. So there have been systematic reviews, mathematical modeling. Then we decided to launch a pilot to look at feasibility of we're using Google phones and doing home-based testing with our NGO partner there to basically use home-based testing as a way to deliver a targeted prevention package to the couple in that room. So if it's a HIV negative man who's uncircumcised, his wife is positive, he's a very high-risk man, we recommend male circumcision, right? And we actually have ways to refer and to follow up on those referrals. So the idea is to try to target the prevention package specific to that person in their household. And we've done the pilot now. We're going to wrap up next month, actually. So we've enrolled a number of households. This is sort of door-to-door household HIV testing. And we've identified a number of people who've not been tested before and have been able to deliver the targeted prevention prescription for them. And we're following up on how good the uptake is. So again, it's feasibility, but now Dr. Kellum is looking at taking that same model and trying to expand it in South Africa and elsewhere. I'm also doing a kind of a home-based, I'm utilizing home-based HIV testing as well. This is a community enrolled cohort study we have in Western Kenya. We're actually doing probability sampling using latitude and longitude points. So it's an actual probability sample. We go to households. Our staff, field staff, have to work pretty hard. And they do HIV and pregnancy testing in the house. So you can see here where all the sampling points are. Even if it puts you in the middle of the sugarcane plantation or the rice paddy, you then have an algorithm for finding the closest house and offering people to enroll in the study. And what we're finding, and this is Western Kenya that's had a lot of initiatives, in 1 in 4 households, one or both of the heterosexual couples are HIV positive. 13% of women are pregnant that day. 2% of them are pregnant and positive. So this is really high disease burden. And we're really doing this study to look at how we do a better job of integrating people's desires to have children, which is a really powerful desire, with reducing transmission risk when there's so much HIV around, right? So when we think about these combination prevention studies, as I said, they're really, it's newer to think about it in a very rigorous way. We are really talking about feasibility studies at this point. Well, how do we get it to the next level of saying, where's the efficacy, much less the effectiveness, right? So what would you do for a phase 3 study of a prevention package that's now maybe 6 things in it instead of just 1? So people are looking at different approaches. One big question is, do you really try to do it as a randomized trial, or do you try to do it as a demonstration project, like in one area, which may have, better public health implications or information to give. So, it's not all about just having a randomized trial for everything. And there are some difficulties. Doing a cluster randomized trial, for example, you need at least 6 paired communities. Well, it's actually hard to find that with high incidence, ironically enough. Factorial designs, where you hope to get sort of 2 for the price of 1 studies, that works unless the multiple interventions are not independent. And so the question is always with HIV prevention is, what's your comparator? And when the standard of care for HIV prevention is changing as you go, it's hard to be able to assess that. So right now, actually, the CDC has an RFA out for they're going to fund one $20 million project to evaluate the efficacy of a combination prevention study. There's not many places you can actually do this in the world, and they have very, very rigorous levels that they've set out for how much coverage you have to show and how much impact you have to show. They basically, so it's going to be very interesting to see who gets funded for that and who can pull that one off. But at least there will be at least 1 efficacy study. So other study design issues, you really want to think about, are you testing the package as a whole or testing its individual components? You're going to look at biomarker outcomes or sort of process measures. You really are having multiple targets. And in a way, you're measuring the outcome on people who are different from the ones who might have been delivered the intervention, right? When you think about antiretrovirals for prevention. We've talked a bit about some of the issues with HIV incidence assays not being perfect. So there are some other surrogate ways to look at that. Process outcomes are helpful, actually, to inform us about what works in a program or what doesn't. And so Jim Hughes, who's a biostatistician, has sort of laid out some principles. And when you think about designing these combination prevention packages, if you don't know the effect of the various interventions, just do a standard RCT. But in general, the idea is that we should probably avoid mixing interventions that are known and unknown outcome. And if we know the individual components are efficacious, then really looking at the process and the feasibility measures might be enough. So just to wrap up here, we know that we're still having multiple new cases of HIV for everybody who does get put on therapy. We have to think of ways to do better integration of evidence-based approaches. We need to understand what's called implementation science better. How do we actually get the science that we do know works out there into population-level practices? And this is a whole new area now. And we can just, in going quickly through UN AIDS, we know that the approaches that work aren't actually out there at the high enough coverage levels that they should be. So this is just coverage for sex worker prevention, MSM, and IDU. It's declined from 2008 to 2010. Availability of sterile syringes, terrible. There's been no needle exchange in sub-Saharan Africa, although the government of Kenya just agreed to do that, and we're hoping to evaluate it. And prevention of maternal to child transmission, the complete success story in HIV. Complete success story, and yet what are the coverage levels? This is antenatal coverage, and this is PMT-CT coverage. Look at Nigeria. A lot of HIV-positive pregnant women, they're not coming in for much antenatal care, and they're not getting much PMT-CT, right? Medical male circumcision, beautiful. 3 RCTs, you never see confidence intervals that close together. We know this works, right? And in fact, we know from modeling that it has an even bigger impact than we thought, because there may be some helpful effect of transmission from male to female. And yet, how rolled out is it? So this is UN AIDS 2010 data. Small number of sites in these high burden countries. Number circumcised, I mean, small numbers. This right here, the 90,000 people in Nyanza, that was Kawango Agate, who was our colleague at University of Washington. She had her field staff out there. She did 40,000 circumcisions in a month. So it can be done, but you have to have the resources and the commitment. And we know it makes a difference. If you really scale up the interventions, look at this difference. 25 million infections could be averted. If we scaled up what we know works, what we have now. And so we really do need to look at doing that globally. The combination approach really might be helpful. So I would say, in sum, that even in lieu of a vaccine, which we won't have a highly effective vaccine anytime soon, we do have ways to control the pandemic. And as always, it's still about political will, it's about the resources, and it's about working with the community. And so that is always going to be the same.